Hello, everyone here and online. For those who don't know me, my name is Linnea Zimmerman. I am an associate professor in the Department of Population, Family, and Reproductive Health, and the lead for the Women's Sexual and Reproductive Health area of interest. And it is my great honor and privilege to introduce our two speakers today. Most of you probably already know, but if there are any new people in the room or online, Dr. Suzanne Bell is an assistant professor in the department. She received her MPH from University of California, Berkeley, and her PhD from here. And she has spent her time largely focusing on abortion research, on improving our measurement and understanding of how to measure abortion, how to understand quality of care for abortion, and largely has been working internationally, but with the changing political landscape in the US, has started to focus a little bit more domestically. And she is the co-PI of an NICHD-funded R01 with Alison Gemmill, who is also an assistant professor in the department, also received her MPH from the University of California, Berkeley. Same cohort. As well as her MA, I learned that today, and her PhD in demography, all from University of California, Berkeley. And she focuses on fertility in the United States and abroad and in maternal and perinatal health. And as I mentioned, is also the co-PI of this R01. So we are very pleased to hear about the work that they have been doing on this incredibly pertinent and timely issue.
Thank you, Linnea. That was a lovely, lovely introduction. It's nice when your colleagues get to introduce you. She knew all this already. Okay, so yes, I'm Suzanne Bell. Alison Gemmill and I are going to be talking about the unequal impact of abortion bans on fertility and infant health in the US. And I first want to acknowledge our amazing collaborators on this work, Selena and Amy, you may recognize from the department. And then the two co-leads on the statistical side, Alex Franks and Avi Feller. We could not do this work without everyone pictured here on this slide. So I'm sure all of you in the room are aware of the drastically shifting landscape of abortion policies in the US in recent years. Starting in 2021, Texas passed Senate Bill 8, which banned abortion as early as 5 to 6 weeks gestation, and it was the most restrictive abortion law in the US at the time. And then a year later, in June 24th, 2022, which I remember because it's my birthday, the Dobbs decision came down, which dismantled federal protections for abortion and sent the decision back to states with regard to policies around abortion. Currently, we have 13 states that ban abortion completely, 4 at 6 weeks gestation, and another 4 pre-viability, which is prior to roughly 22 weeks gestation. And there were several, 10 states had ballot initiatives in the most recent election, several of which passed. But primarily it's Missouri that in the coming months, we hope, we'll see changes in their abortion policy. Others, it was changing already or cementing already, protective laws that are in those states. But this is going to continue to shift in the coming years. This is not settled policy. So this map is different every time I present on this work. But to give you a little bit of the abortion landscape prior to Dobbs and SB 8, I want to situate where where abortion was in the kind of fertility regulation landscape. We had about 20% of pregnancies ending in abortion prior to 2022. Abortion rates were higher for groups that experienced structural disadvantage. We had rates 2 to 3 times higher among Black and Hispanic people, those experiencing poverty, and unmarried individuals. And overall, the rate was roughly 14 abortions per 1,000 women of reproductive age. And also prior to abortion, medication abortion had been growing as a share of all abortions being provided through the former healthcare system, and it represented roughly 53% of abortions. And so there's a lot of text here, and I just want to kind of orient you to Alison and I's thinking around how abortion policies can ultimately impact pregnancy outcomes and the continuation of a pregnancy. So this was a conceptual framework we used in our R01 application. And you have on the left, someone becoming pregnant, and regardless of the policy, they might have an inclination to continue a pregnancy or intend to end the pregnancy, resulting in an abortion. Those decisions can also change. Perhaps you get a fetal diagnosis, maternal health diagnosis, and that changes your decision. And for some people, they go on to continue a pregnancy or change and terminate the pregnancy. Ultimately, all of these pregnancies are at risk of some poor pregnancy outcomes, which we intended to look at severe maternal morbidity, preterm birth, low birth weight, and infant health. So there's factors that, regardless of policies, we know always impact likelihood of obtaining abortion, as well as likelihood of experiencing poor pregnancy outcomes. But then there's a number of changes that we suspected were happening, and there's now evidence of it happening in the years since Dobbs. Introducing new barriers to accessing abortion services in the form of these policies that are increasing distance and money required to obtain an abortion. There's factors influencing maternal health outcomes among the abortions that ultimately are received regarding when those abortions occur, potential uses of unsafe methods, poor management of pregnancy complications, waiting until the pregnant person's condition really deteriorates before providing an abortion. And then many factors influencing poor pregnancy outcomes, again, specific to the post-Dobbs environment. So factoring all that in, what do we actually know so far about the consequences of these abortion bans? We've seen unprecedented shifts in the way that abortion is delivered in the US, as well as pregnancy care more broadly. Specific to abortion, we saw initial declines in the number of abortions provided in states that banned abortion or restricted it heavily. Here you have the darker the gray, the fewer the abortions being provided in these states, with a reference to the couple months prior to Dobbs. This is for April 2023. We also know that there's been a huge shift and increase in interstate travel. So prior to Dobbs, roughly 1 in 10 abortions involved travel out of state. Now that's 1 in 5. And Guttmacher is doing a lot of great data tracking this. This is for Texas specifically. And we know that now 20% of abortions are being provided via telehealth, which is up from 5% prior to Dobbs. And roughly half of these now are being provided under SHIELD laws. And there's, concurrent with all of this, huge increases in self-managed medication abortion. And actually in recent years or recent months in the last year or so, nationwide, we've actually seen more abortions being provided post-Dobbs than we did prior to Dobbs. Nonetheless, at least initially, we have seen significant increases in fertility. So all of these things are shaking out such that some people are still unable to obtain a needed abortion in states that banned abortion. And we're concerned in particular about the potential inequitable burden of these policy changes on specific populations. So for the heterogeneous impacts of abortion bans, what do we know about this so far? Well, thinking even prior to Dobbs, we knew there were significant differences in pre-Dobbs abortion rates, as I've already mentioned. And these same populations have greater difficulty overcoming barriers to abortion. Thinking about what we know in relation to accessing healthcare in general and abortion specifically. And then there's state-specific characteristics, demographic compositions, and social and economic policies that shape access to reproductive health care and childbearing choices. And abortion bans may be interacting with these underlying state characteristics in a way that amplify some of these ban impacts for certain populations in particular. And there's been 2 key studies that start to look at these sources of heterogeneity. One is looking at the fertility effects of the first 6 months of Dobbs by race, ethnicity, and maternal age, just overall. And then another study looking specifically at race, ethnicity in Texas, SB8. And so we are starting to understand potential inequitable impacts, but a lot more there to explore, particularly looking at heterogeneity within and across states.
Okay, so thank you so much for setting the stage, Suzanne. And so she's been talking about the abortion landscape and what we know so far about fertility, but one of the first health outcomes that we were able to study is infant mortality. And so that's another outcome we'll be discussing today. Just want to again set the stage. What I'm showing on top is a headline from the Washington Post right after Dobbs happened, so published in August 2022. And this was a historian who was already suspecting that Dobbs was going to be exacerbating longstanding disparities, racial disparities in infant health or infant mortality. And this is a chart from NCHS showing infant mortality rates over time in neonatal and postneonatal. And what you see is since 1995, we have made significant progress in reducing the infant mortality rate. It did tick up with COVID a little bit because of COVID's impacts. But in 2022, we're talking about a rate overall at 5.6 per thousand. So that's important to keep in mind when we're going to show you impacts of these bans on infant mortality. You'll also note some very stark racial and ethnic disparities with non-Hispanic Black and non-Hispanic AI or American Indian Alaskan Native populations having much higher rates of these infant deaths, and those again have been very long-standing. So there's several mechanisms that we can think of that might link these abortion bans to infant mortality specifically. So you saw the conceptual framework, but in addition, I wanted to highlight congenital anomalies because that's going to be a big part of the story here. So this is a report from NPR that came out last year, last year, July 2023. And this is about 2 cases in Texas, because again, Texas passed SB 8 a year prior to Dobbs. So there's a lot of anecdotes coming out about Texas and their stories and testimony now as well. And this specific woman, her name is Samantha Casiano, and she found out early in pregnancy that her fetus had anencephaly. So no skull was present. So she had the option, or she would have had the option to terminate if abortion were still legal in the state. And there's an anecdote from this story that I think sums up this experience very well. Samantha reports that she asked her OBGYN after giving the anencephaly diagnosis, I asked her, hey, what are my options? And she says, well, because of the new law, you don't have any options. You have to go on with your pregnancy. And the story tells 2 different paths in that Samantha was unable to overcome barriers to abortion and had to give birth to her daughter, Halo, who died 4 hours after birth, whereas another woman with more resources was able to leave the state and get the care that she needed. So what do we know about abortion bans and infant health or infant mortality generally? So prior to Dobbs, we had research showing that there was an association between abortion restrictions broadly and infant mortality rates. So of the 16 states with 2020 infant mortality rates that were significantly higher than the overall US rate, nearly all were considered hostile to abortion, of which now 13 ban abortion entirely or restrict it pre-viability. Again, there's other studies showing this association between state abortion law restrictiveness and county level infant mortality rates. And the last study here used a more causal analysis or design difference in difference analysis and found that gestational age limit laws were associated with excess infant deaths in those areas. Okay, so we did write about this topic already in terms or in reference to the Texas abortion policy, which again happened in 2021. And that's because 2022 data were made available so we could start to evaluate these impacts. And this was published earlier this year. We found that the Texas policies particularly was associated with a 13% increase in infant deaths or an 8% increase in the infant mortality rate. And then at the time, we can only look descriptively at what was happening with deaths due to congenital anomalies. And there was strong suggestive evidence that much of this increase was driven by deaths due to congenital anomalies. That's me too? Yeah, okay, so gaps in the literature, just to summarize where we are now. So with fertility, there's no examination of subgroups that more directly reflect structural or resource constraints. So we're gonna be looking at those subgroups in our paper. And there's no joint estimation of variation of impacts within and across states. So far what we know about racial disparities, for example, in fertility impacts is summed at the banned states level. So we don't know what's happening within each state. And then we don't have a direct comparison of impacts across groups. And the one study that a lot of people have cited so far only looked at the first 6 months post the ban, so we're gonna look at a longer time frame. And in terms of infant health, there's been no assessment of post-Dobbs impacts on infant health in states with abortion bans, so that's what we're gonna be doing. And again, limited evidence on how so far abortion bans may exacerbate longstanding racial ethnic disparities. So our study objectives First, we're going to estimate sociodemographic variation and the impact of abortion bans on subnational birth rates, so at the state level in the US through the end of 2023. And the subgroups we're going to look at are by age, race, ethnicity, marital status, educational attainment, and insurance type. And that's because those are the variables that we have available on the birth certificate. And then for looking at infant mortality, we're going to do this again through the end of 2023. And we're going to look at race, ethnicity, timing of death, and cause of death. We don't have the other types of demographic variables that you see for the fertility because we're using death certificate data. Okay.
All right, so on to data and methods. So for the fertility analysis that I'm going to be focusing on, we're using bi-monthly data, so January, February, for example, counts of live births for all 50 states in the US and the District of Columbia from 2014 through 2023, so that last year is when we start to expect to see exposed births. And these data are compiled by the National Center for Health Statistics, accessed through CDC Wonder, the 2023 data flagging that those are still considered provisional, but more than 99% complete. The denominators, since we're looking at rates, are women of reproductive age, 15 to 44, for each state year during this study period. And these data come from a combination of census data, as well as information on the distribution of reproductive age women's characteristics with regard to education, marital status, and income as it relates to qualifications for Medicaid. And then using this information, we're ultimately modeling birth rate, which is births per 1,000 reproductive age women. The exposure here specifically are states that imposed a complete or 6-week abortion ban, and that includes 14 states that imposed it shortly after Dobbs, and thus we saw the exposed cohorts of births for almost the entirety of 2023. And these states include Alabama, Arkansas, Georgia, Idaho, Kentucky, Louisiana, Mississippi, Missouri, Oklahoma, South Dakota, Tennessee, Texas, West Virginia, and Wisconsin. And so the pre-policy period includes roughly January 2014 through about December 2022. And there's a little caveat there because, as you recall, Texas actually imposed their 6-week ban almost a year prior to Dobbs. So their exposure window actually starts earlier. And then the treated period is roughly January 2023 through December 2023. And as Alison mentioned in relation to the study objectives, we're looking at this for a number of subgroups with regard to age, race, ethnicity, marital status, educational attainment, and insurance payer for the delivery.
Okay, and then a very similar approach for infant mortality, except we're going to actually have to look at it by the biannual level. And this is because infant mortality is a really rare outcome. And when we want to analyze within state effects and within subgroup or within state subgroup effects, we have to use a larger time period. So we're using biannual data, counts of infant deaths, from 2012 to 2023. Again, the 2023 data are provisional, but mostly complete at this time. One interesting thing about these data is we had to use CDC Wonder to download them, which means that they suppress infant death counts that are less than 10. So in our models or in our approach, we impute suppressed data using a separate model. And then the denominators are going to be the live birth data that Suzanne just referenced. And then for infant mortality, again, a similar approach. Our outcome is the infant mortality rate. Our exposure is, again, the 6-week or complete abortion bans in those same states with that lagged data from Texas. And then again, the subgroups that we're going to be looking at, race, ethnicity, we have to aggregate by non-Hispanic, white, Black, Hispanic, and other. Unfortunately, we can't look at non-Hispanic, Alaska Native, American Indian separately. It's just a small group, but we're aware that that's a big limitation. Timing, we are going to look at neonatal versus non-neonatal, although I don't think I included those results today. But we also look at cause of death here. And here we can actually start to look at the causal impact on these separate congenital and non-congenital causes. Okay, so just want to orient you into our methodological approach. So what we're doing is akin to a general interrupted time series approach. And I just wanted to present this here to provide some intuition for this more advanced complex model that we're going to be using. But the idea here is that on the x-axis, you have time, and you have before the intervention, after the intervention, with that vertical line showing where the intervention here, and here that's going to be the policy change. And your outcome measures on the y-axis, so this could be fertility or infant mortality, and then we have our observed rates, the intervention happens, and what we want to do is generate that counterfactual. That is the tricky part of this analysis, as Suzanne will explain. And eventually, the way that we estimate our causal effects is comparing what we actually observe, what happened, versus what we thought would have expected based on our counterfactual. So those are our effect estimates.
Yeah, so these data start to elucidate why we can't just do this simple sort of interrupted time series approach, because these are what the data look like. This is the monthly fertility rate for all 50 states and DC for most of the study period. And you see there's a ton of variability both across and within states over time. You're generally seeing a secular trend with fertility decreasing. You see really pronounced seasonality in fertility, and there's similar patterns with regard to infant death as well. And then it's hard to see here in the jumble of gray lines, but you also see a bit of a baby bust and then rebound in relation to COVID, and that happens right before Dobbs. And so all of this needs to be accounted for in our model to feel confident that the counterfactual that we are comparing our observed estimates against are really reflecting what we might have expected in the absence of these bans being imposed. And so ultimately, our analytic approach is a Bayesian panel data approach. And for people who might be familiar with two-way fixed effects, this is just kind of a zhuzhed up or fancy two-way effects that we think is perhaps better capturing some of this cyclicality and these trends in the pre-policy period. The model is an over-dispersed Poisson model, and this is a latent factor model. So essentially, the model has a varying number, depending on the analysis, latent factors that are trying to model the pre-policy period in the data to capture that cyclicality, those trends in COVID. And that is why it kind of goes above and beyond perhaps some of the more simple or straightforward methodologies that you could use to analyze policy exposures. So for the fertility analysis, we're looking at modeling the bimonthly log number of births with a population offset. So ultimately, our outcome is a rate. Similarly, for infant mortality, we're modeling the biannual log number of deaths with a live birth offset. And ultimately, we're running an analysis overall for the total, and then separately for each characteristic of interest. And within that, modeling each state by subgroup specific impacts within a given characteristic. So for instance, we run the race ethnicity model, and each of those subgroups are in there and have to sum to the total impact for that model. And states without bans, as well as the pre-exposure outcomes in the ban states, are contributing to our understanding of the counterfactual. So moving on to our results. How are we doing on time? I have no sense, and I don't see it. 12:38. Okay, we're good. So this is just to give you a sense of the data. We've normalized the birth rates here over time. And you're looking in red at the exposed, excluding Texas in yellow, and then unexposed in gray. And you see generally similar trends. And then the dashed yellow line is when we would start to see exposed births in Texas. The dashed reddish line is when we'd start to see exposed births in the other ban states. And then gray is just the unexposed for the entirety of the study period. And we do start to see this divergence. I think even with all the data points that you see in the background, it's again really conveying the importance of our model in trying to capture these pre-policy patterns in order to accurately predict the counterfactual. So now we get to our model in relation to the data. So the model fit is on the left here, and you see prior to the dashed line, which is when exposure begins, these observed data points are tracking quite nicely along the red line, which is the model fit. The gray area is the 95% credible interval. And then afterwards, you're starting to consistently see the dots are above the predicted model. And then in the right, we have the births in all ban states. And so this is the difference basically between the counterfactual and the observed, which in the pre-policy period on average is 0. And then you see this divergence from that horizontal dashed line at 0 beyond the dashed line, which is when policy exposure begins. And that really starts to move away from the 0 line. And ultimately in that post-exposure period for all of 2023, we see a 1.6% increase in fertility above what we would have expected in the absence of these abortion bans. And that's equivalent to roughly 20,000 excess births, or 0.9 births per 1,000 reproductive age women in 2023. So now I'm going to go through our results by state and some of the characteristics that we are looking at. So these are the estimated state-specific average effects of abortion bans on the overall birth rate in each state. And the top, just to orient you to these figures, they're all going to kind of look the same. We have all ban states at the top. This actually corresponds to the results I presented on the last page, just in a different form. And then given Texas is a large state, it had a longer exposure period, we present all of our analyses also with all ban states excluding Texas for both the fertility and the infant mortality paper. And we see that there's a smaller effect for all of those ban states when we exclude Texas, so a 0.9% increase, and that's equivalent to 5,600 excess births. And then all of the states are listed alphabetically. We see a range of an effect estimate from 0.6 to 2.1 above expectation, with the largest impacts and significant impacts in Kentucky, Mississippi, and Texas. And just overall, we see that we see 2 times the percent increase in southern states compared to non-southern states. And that posterior probability of a subgroup difference was 0.97. So definitely some geographic regional variability in the impact of the bans, which if you think back to that graph or map that I showed on the first slide, you could understand why you might expect to see larger impacts in the South. When we look by age, the impact among younger women, which is we're just defining as less than 35, is larger than the impact among older women. Here's the overall, whoops. And we generally see a 2% increase among both of these population, whereas there's little evidence of an impact among women aged 35 to 44. More variability between these subgroups in relation to the absolute impact, which very much corresponds to the underlying rates in fertility rates in these populations. And just to flag also, you're not intended to make sense of all of those specific interval plots, but just to say that the pattern is quite consistent across states in relation to age. With regard to race ethnicity, we have strong evidence of a large estimated effect for, in particular, racially minoritized women in comparison to non-Hispanic white women, with a posterior probability of differences across subgroups of 0.98. And the state-specific Hispanic, then it's a little shifted. Okay, no, it's still okay. Non-Hispanic Black increased 2%, similarly for Hispanic and the other catch-all group. So there's really consistent findings with regard to the relative impact and similar findings with regard to the absolute impact. And again, very similar patterns across states, though most of the states' 95% credible intervals include 0. And these range from 1.6 to 2.4 for Hispanic and 1.2 to 2.5 for non-Hispanic Black. With regard to marital status, we see a nearly 2% increase in fertility among unmarried women and essentially no increase in corresponding birth rate for married women. And this ranged from 0 to 2.6% across states, with the largest in Oklahoma at 2% and Texas at 2.6%. When we look by education, we see variation in particular based on college degree completion, with a posterior probability of subgroup differences of 0.99. And here's our overall ban states. But generally, the largest impacted group were those with only a high school degree, with nearly a 3% increase in fertility among the subpopulation averaged across all of the states. And the state-specific estimates range from 1.6 to 3.1% increases above expected levels of fertility for those with only a high school degree, and 1 to 2.5 for those with some college. And just flagging that these were largest among residents in Alabama and Mississippi. And then lastly, we have the estimated state-specific average effects of abortion bans by insurance. And we see considerable variability in the state-specific estimates here, which happy to talk about why we think that might be. But overall, we see a nearly 3% increase among births to those whose birth was paid for by Medicaid, which is equivalent to 1.2 excess births per 1,000 reproductive age women who would qualify for Medicaid. and the largest estimated effect in southern states, Mississippi, Alabama, Missouri, and Louisiana in particular. With that, I'll turn it over to Alison. A lot of results.
That was a lot of results, and I know those figures are a lot to get through, but I think the results tell a pretty consistent story, and we can go into the implications. So results for infant mortality, again, they're going to be sort of the same type of figure, but this is overall, and I think I have this. So in banned states overall, we're finding that this is looking at the rate now, not just counts. The infant mortality rate increased by 5.7%. But there was significant or substantial variation by state. So this wasn't always uniform across states, although we are seeing many states that are in that more positive area. So Kentucky stands out as one of them as having much higher infant mortality, and Texas. So in Kentucky, we saw a 7.5% increase, and in Texas, we see 8.9%. And I don't know if people have been picking up on this, but Texas always comes out as being one of the states that has these effects across all models. Okay, so these results were really interesting to me. So this is looking at just congenital and non-congenital overall. And we have separate charts for this by state, but we're not going to show them because we think there's lower statistical power here. So once we get into the states, it's kind of harder to see true effects. But here we have an 11% increase in the infant mortality rate due to congenital deaths. And that is statistically significant, but we also know, and I think this is a really important finding, we find that it's also non-congenital deaths where we're seeing an increase in infant mortality. So it's not just this mechanism of people being denied care to terminate a pregnancy with a diagnosed congenital anomaly. There's something else going on here. And here we have the impact of the abortion bans by race, ethnicity. And these are really heartbreaking numbers to report. So what we see is a positive impact for non-Hispanic white. So it is a 5% increase, more or less. But we really see a large increase in non-Hispanic Black infants, moms. So 11.3%. Whereas with Hispanic, it's not statistically significant. It is positive at 3.5%. And non-Hispanic other, we're seeing a pretty large impact at 10.4%, but the confidence interval overlaps 0. So that's something to keep in mind here. Because the result is so large for non-Hispanic Black here, we are able to look at state-specific differences. And here we do have them by state. And when we look at the state-specific range, they estimate from 5% in Missouri to 17% increase in infant mortality rate in Kentucky. And 6 of these states, of these 14 states, have effects greater than 10%. And these states are mostly in the South. And when we do that, what is it? I always say it wrong. Posterior probability. I always say that wrong or incorrectly. It's significant at 0.99. So these differences are quite substantial and significant. Okay, I didn't show neonatal and post-neonatal, but we do see a strong effect among neonatal deaths, as you might expect, because a lot of those are going to be the congenital anomalies. A little less of a suggestion with post-neonatal death. So. Do you want?
Yeah. Okay. All right. So we're on to the discussion. Just to summarize briefly, we see quite strong evidence that the birth rate increased above what we would have expected in the absence of these abortion bans in states that banned abortion, nearly 2%. And these effect estimates are smaller than what prior studies had seen, which were more in the 3 to 4% range, which we think is likely due to differences in our analytic approach that may better capture some of those pre-policy trends and our inclusion of a longer post-exposure timeframe to estimate this policy impact. These results are, on the other hand, quite similar to some of the magnitude of fertility impacts in relation to recent population-wide events. So the baby rebound following the COVID baby bust was about 1.4%. And it was a 1.3% increase in fertility following, what was it, a 1 percentage point change in the recession in
Or in GDP.
GDP. There we go. Something related to economics. Outside my wheelhouse. And the largest impacts were among those experiencing the greatest structural disadvantages. And this is consistent across states. So minoritized populations, people with less than a college degree, people whose birth was paid for by Medicaid. And these start to emerge in relation to the infant mortality increase that we observed as well, which we estimate is roughly 5.5%. We see an outsized influence of Texas, and that holds in the fertility data as well. And then double the impact of abortion bans on non-Hispanic Black infants, with that 11+% increase in infant mortality among that subpopulation, and larger relative increases among the congenital deaths in particular. I also want to flag in relation to infant mortality is we actually think, looking at the rate, which is what we did in this paper, that this is more conservative, which we've talked about a lot, because the mechanism is also just, there's more births based on the first half of our presentation. So there are more births that is kind of being folded into the fact that we're looking at rates. So the denominator also increased. And so when we kind of take that into account, we actually calculated kind of post hoc based on the number of excess births that we saw, that the infant mortality rate among those excess births is 4 times the national or the infant mortality rate in those states that banned abortion. So there's a real compositional shift in the people who are having births in these states that ban abortion towards populations at a greater risk of infant mortality. And then briefly, some of the strengths, we're using complete panel data for the entire US for this whole period. This is a really amazing resource that we have and can draw on. And here we have this relatively discrete and extreme policy exposure. We're not looking at like small changes in the way in which abortion is delivered in a state. These are quite drastic changes in service delivery. And we're using these robust causal inference techniques that really leverage variation across state and time and model this seasonality and secular trends and all these things happening pre-policy to, we think, do a good job of modeling that counterfactual. And then in relation to fertility, these are the first evidence of exploring some of these demographic factors that we think are closer to some of those measures of structural disadvantage beyond just age and race ethnicity, which is all anyone had looked at prior to this. And we're starting to partially disentangle state-specific contextual factors versus sociodemographic characteristics. And then in relation to infant mortality, a real strength is our ability to impute these suppressed data, which I think is why no one has looked at this before, because when you have small counts of things, it's on CDC Wonder, if you want to look at state level and subgroups, it's just all going to be suppressed. And so working with our amazing biostatisticians, this allowed us to do this sort of time-sensitive policy relevant analyses, which I think is a real strength of this model that we hope to move into other analyses as well, looking forward.
Okay, so some limitations. There is some potential for spillover. And you're better at saying what this is than I am. This is your area of expertise.
So the challenge here is that essentially all states were exposed to Dobbs, because a lot of the states that did not ban abortion were making kind of changes that were improving access to abortion. So we might be concerned that we're overestimating the effect of these policies if in fact fertility is going down because abortions are going up among residents in California, New York, Illinois, et cetera. So we actually did some sensitivity analyses excluding all those states where there's evidence of large increases in the resident fertility, or excuse me, abortion rate. And we essentially see very similar results, slightly attenuated. But that's the main concern there that I think other people are.
Yeah, other people in the abortion space have brought this up, and they're like, well, you need to account for spillover. And we have in our sensitivity analysis, and we do show the same kind of findings. Okay, so another limitation is we're using this provisional data, but it's close to complete. But in future work, what we're going to be doing is actually arraying, at least for the infant health outcomes, we're going to array them by conception cohorts rather than when they were born or when the death occurred, and that will help us avoid potential exposure misclassification. There is a little bit of it going on here, but not too much. And we are going to eventually look at the linked birth certificate, death certificate data, because you'll note that we only looked at race ethnicity for the infant deaths, but with the linked data, we can look at those other characteristics of the mother. We're unable to examine joint probabilities and intersectionality. Obviously, these categories are very discrete, and we're not looking at any combinations of them, but this is an area that our statisticians are interested in exploring in the future. Again, it's very challenging to do that. And we now have restricted individual level data where we can do that, right? And we're using these proxy income measures for fertility, so it's not ideal, or they're not perfect measures of socioeconomic status, but they're good enough. And state-specific insurance estimates. Oh yeah, well, we'll just go through that. We're just fine. No, okay. The way we calculate insurance is there's no, Medicaid definition in the denominator in our ACS data, so we kind of proxy it, but we think we do a good job. And again, infant mortality is such a rare outcome, so we're just dealing with low statistical power throughout. But you'll note that a lot of those estimates are in the positive direction, even if they're not technically statistically significant at 0.05. So implications, I think you all can think about implications of this work. Just to sum up, we think that there are profound health, social, economic implications of being unable to obtain an abortion. So these are just the two outcomes we're studying. I highly encourage you to look at Diana Green Foster's work around the turnaway study to look at other outcomes that or to consider other outcomes that we cannot study with these vital statistics data. So state-specific policies and social contexts may present additional barriers for disadvantaged women, so we're not even layering that on top of these estimates. And then again, we're seeing quite concretely that these bans are exacerbating existing health disparities and probably across the life course. So this is the end of our presentation. I just want to highlight some future work that we are working on, and we're funded by both NIH and the Society of Family Planning. So we are going to be looking at maternal morbidity soon. We have data for 2022. We're hoping, or we will get data for 2023, but that won't be available until this time next year. So there's this serious lag that we are dealing with, but hopefully we will start looking at 2022 data. And that's where we're going to start hopefully looking at outcomes related to high-risk pregnancy care, especially for miscarriage management. We are going to, oh yeah, and we're using hospitalization data for that. So we have that data in hand now up through 2022. And then finally, we're going to be looking at other outcomes related to infant health. Preterm birth, low birth weight are next on our agenda, but then also maybe outcomes related to infant morbidity in the hospitalization data. So thank you so much, and we're ready to take questions and want to acknowledge our funders, and thank you all for listening. And for those of you who have provided support to us along the way on this project, we really appreciate it. So thanks.
Good, before 1, that was our goal, finish at 1. Okay, so lots of time for questions.
Yeah.
Yes.
Mm-hmm. Speculate, yeah. So for those who couldn't hear online, she was asking about other mechanisms linked to infant death that go beyond the congenital anomaly finding. So this is something we've talked a lot about, and this is all again speculation, but I think some of it is going to be the compositional change in people giving birth, as we saw with the change in the fertility rates. The fertility rates were shifting in that more disadvantaged populations were having births above expectation, and if those populations are the same populations that have this higher underlying risk for infant mortality for various reasons, then that could explain some of this. But we also think that maybe it has to do with maybe even access to care and the potential correlation between maternal complications and infant complications. So in the Texas study, when we looked at descriptively at different causes of death that were increasing in Texas, but not in the rest of the US, we did see an increase in babies dying due to maternal complications, and also necrotizing enterocolitis, which is another complication. And that
Unintentional injuries.
and then, yeah, the other one that's really interesting that I would like to study has to do with unintentional injury. So those would be like accidents. And we could hypothesize maybe a link with the consequences of unintended pregnancy, especially for people with limited resources. I'm also thinking about short interpregnancy intervals. There has been a study that shows that short interpregnancy intervals are linked with infant deaths of the subsequent child due to accidents. Because if you can imagine taking care of 2 kids under the age of 1, that's a very challenging circumstance. So yeah, a lot to explore there. And we're hoping that with, again, these more advanced models, we can look at those subgroups that have very few cell counts or small cell counts, but we'll be able to disentangle that a little bit more to get at those mechanisms. Yeah.
And I don't know whether you mentioned the actual absolute number of excess births. So we're talking about like a really small number. It's 400, I mean, relatively speaking, 469 excess infant deaths is what we estimated for for all of 2023 across all banned states. So starting to disentangle causes further, there's going to be limitations to that, but congenital, since it is the leading cause of infant mortality, that was a large enough group that we could at least dichotomize cause of death by that. But it's a great question.
Yeah.
Caroline? Mm-hmm.
Wondering if you've seen any publications of mortality in those states versus other states, those Dobbs that have nothing to do with abortion, like
Just overall general mortality.
Motor vehicle accidents or something. Okay, so for people online, Caroline has some doubts about our counterfactual. No, I'm just kidding. I'm just kidding. No, she's thinking about other placebo tests that we can do to really make sure that our counterfactual is getting at what we think it is, and potentially looking at a different outcome that it would be unrelated to the policy to see if that varied after the policy implementation between states that had bans and states that did not have bans. And that is a good point. One of the things that we did do is we did do a placebo and time test. So we did shift the intervention to, I believe, 2019, and to see if there were any effects there, and there was nothing. So that was reassuring, but we could think about a different placebo test with a different mortality outcome unrelated. So that's a good idea.
I think the one thing that we keep coming back to is that across these 13 states, it would have to be something happening in all of those states at the same time, unique to that post-policy period. What do you think?
She's whispering something. Substance use.
But that was happening already. That's been a long-term trend. So if it increased markedly at the same time that the policies were imposed, we would not be able to disentangle that.
Post-COVID, yeah.
Yeah.
Well, we do have the Rust Belt states in our counterfactual, so, but it's a good point.
Yeah.
And we should do
And
everything
we could think about, rerunning with a smaller subset of states that we at least intuitively think are more similar. So that's something we could definitely consider. Yeah. Thank you for that. Lee.
Yes, fascinating research. So a couple questions and maybe one comment. So I think it may be touched upon already. I was wondering if and how you were teasing or control for the COVID, associations, I guess. I'm trying to find my word here, but you're trying to get to causal as well. So that's one question. And the second one is, for those, subgroup analysis, did you also control for those other social demographic characteristics as well? And lastly, I guess, what is the rationale to also look at the 67% probability or confidence band, which is, pretty liberal indicator to look at? And last comment is, sounds like you have the access to the through the research data center, the restricted data already. would that, make it possible for you to then go back and maybe, not do the imputation and relook at some of the more sort of, higher resolution data or analysis that could use that RDC data? Is that over?
I can take some of those. So the COVID piece is being modeled by the latent factors in that Bayesian panel data. We don't have a specific coefficient to pull out that's like, this is the effect of COVID in the pre-policy period, but that's what that model is essentially trying to do. I don't know if you want to add anything to that.
Well, also, we think that the effects of COVID were shared in many ways across these states, including states with bans and states without bans. So if the model is accounting for those shared patterns, we could probably do a little more in-depth research to see if the states that have bans look very different in terms of their COVID response, but I don't think they do.
I was going to say the covariates. So actually in the Texas work that Alison mentioned, which we looked at both fertility and infant mortality, we did adjust so that the states we were comparing Texas to were essentially accounted for in relation to those the composition of the population. But now that we're getting into exploration of heterogeneous impacts, those are the outcomes that we're modeling for these subgroups. So we couldn't adjust for them since they are actually the outcome. I don't know if that makes sense,
Well,
but this is something that we've talked a lot about and ultimately don't have anything
well, you have
regarding
this
the
too.
composition in here. This is getting at, somewhat to your point. This is actually across, you're like running a regression on our outcomes, but these are the looking at the state-specific effect estimates, then looking at the composition of each of these states in relation to these outcomes. We see that 85% of the variability in our state-specific fertility effects is explained by variability in the education across those states. And correspondingly, when you separately run that with race, 73% of the variability across states is explained by variability in race ethnicity. So this is really why we are motivated to look at that intersectionality now that we're going to have those joint probabilities with the NCHS restricted data. And Lee, to your point, our data application has been approved. We actually don't have the data in hand, but yes, we want to look at rerunning some of these analyses where we don't impute any data and actually compare them side by side and see how those results may differ.
Yeah, and then good picking up on that we use
The
a 67%
and 95.
and 67% confidence interval or credibility interval, sorry, because these are Bayesian estimates, and 95%. And we did that because these are underpowered and that's what we're focusing on. But I think we could, I don't know if we justify them stronger or strong enough in our paper.
Really highlight one or the other in.
Yeah, we focus on
We talk about
the point
that where 0 is included in the 95% credible interval. I think it was just another uncertainty range to highlight. Our stats team were like, this is something that we often do, so we went with it, but we could just as easily exclude that.
Yeah, go for it.
Yeah.
I don't know if this would be on the scope of this study, but could it be due to, a lot of healthcare workers leaving different states as a result of restrictive policies? It's something that they actually or that you might be looking for.
Yeah. Yeah, so the question was about, could some of the impacts among infant mortality be because healthcare workers are leaving states affected by these bans? That could definitely be on the causal pathway. I feel, or one of the mechanisms. We've talked about this a little bit. We think that the workforce composition changes are going to have more of this delayed effect. So it's not going to happen right away after the policy was implemented. But definitely, I think it's under the broader envelope of changes in pregnancy care. So I think it's a good point. And
there aren't currently good data on the extent to which that's happening. I think people are looking at the signal indicated by shifts in residence or application for residencies, but there's not a comprehensive data set where everyone's practicing when. And we'd love to have that sort of data even at the county level to understand if this is in particular exacerbating like the rural or urban disparities in access to maternal and child health care. But yeah, that's a good point. I think, generally using these population level data and looking at demographic outcomes, we don't have a good sense of being able to examine specific hypothesized mechanisms. We're looking kind of overall, what is the cumulative impact instead of kind of adjusting for or restricting for specific pathways, because that is likely a contributing factor. And to the question around pre-policy trends, that was already happening, the declining access to care, in particular in rural areas and also in the South that already had among the worst maternal and child health and well-being outcomes. So we're trying to kind of above and beyond those trends, see what the policy specifically did in relation to these outcomes. That's a great question. I'm sure there's other people also working on just that.
Oh,
Yeah,
Kristen and
Kristen.
then Cynthia, yeah.
Thanks for this. I always love learning more about the interrupted time series. I feel like there's always like new methods people are coming up with, so that was cool. I was just wondering why you started your pre-policy period in 2012. Was it like a recession consideration, or was there some other event you were worried about?
Yeah, so yeah, the question is why start the pre-policy period in 2012, and that's specifically for the infants. And that's because with interrupted time series, you want as many observations before the policy as possible. And if you recall, we're using these biannual outcomes. And so for a given year, you only just have 2 observations. And so we wanted to extend back as early as we could. We used 2012 because that's when almost all states had adopted the 2003 revision of the birth certificate. It doesn't matter as much here, but we just chose that. And I think that was also what was easiest to download from CDC Wonder. No,
Yeah.
there were more better reasons than the ones I just gave, but those are some of them. Yeah. Mm-hmm.
In relation to
Yeah.
2012, I actually don't know, but it's just like state by state.
Some of it was happening after.
Yeah, so there's definitely Medicaid expansion going on in our data. But again, we think the latent factor model is picking that up a little bit, but it's a good point. Yeah.
And that's something actually we are interested in exploring in thinking about these state contextual factors that could influence the impact. There's variability in the exposed states in relation to the timing of Medicaid expansion, and looking at that kind of interaction to see if Medicaid expansion actually blunts some of the impact of this policy in relation to fertility and maternal and child health outcomes.
If you feel any better, we did a comparative interrupted time series looking at the Medicaid expansion on violence outcomes, and it was null. So
Okay.
Yeah.
maybe there's not like that full trickle. And
Yeah.
it's a little bit more medical. So,
Yeah. Go ahead,
Cynthia.
Cynthia.
It's a great presentation, a lot of food for thought. So in thinking about looking at some of the health outcomes now and moving forward and anticipating a lot of other state and federal policy changes, any thoughts about how like the closure of the pandemic public health emergency and Medicaid unwinding is likely to impact variably across states, and whether or not you might tap into like some of the Kaiser Family Foundation kinds of variables to see whether or not those policies independently might be influencing the health outcomes?
Yeah, between Kristen's question around Medicaid and then your question around, yeah, the termination, what, I don't know what the proper word is, but the end of the
Public health
pandemic
emergency,
safety
yeah.
net policies, yeah. No, that's a good point, and we haven't looked at them and how they vary by the abortion environment.
And I think generally, I mean, we're coming up against this challenge more broadly in that these results are for all of 2023. The policies are still in effect in most of these states, and actually more states have become exposed because they've banned abortion. But as you get further away from that initial shock, it gets harder to reliably model that counterfactual. I think some of those assumptions start to break down. And at the same time, you started to see this in some of the kind of background abortion landscape slides that I presented. But the dip in abortions nationally really only happened in like the second half of 2022 into 2023. And now we're actually seeing higher rates of abortion, even in states that banned abortion, than pre-Dobbs. And so
Among
maybe
residents.
yes,
Yeah.
Yeah, so they're accessing telehealth via shield laws, and that doesn't even include self-managed abortion that are not reflected in the SFP and Guttmacher data. And so these are likely, we might be capturing, at least in relation to fertility, short-term impacts of this policy, and people have adapted and figured out ways to access care and maintain reproductive autonomy regardless of their state's policy. I think the mechanisms with regard to infant health outcomes and maternal health outcomes, we might still suspect to see those in a long-standing, long-term fashion, because those are not going to be abortions you access via telehealth or under shield laws. Those are complications that come later in pregnancies or diagnoses that come later in pregnancy that you really need effective evidence-based pregnancy care in order to avert some of those outcomes. And so, yeah, it'll be interesting moving this forward, the extent to which we can still detect some of what's happening as a result of Dobbs, given it's getting further and further away. And there's going to be complicating factors undoubtedly from the Trump administration imposing additional policies that restrict access to sexual and reproductive health care. I'm thinking in particular about their likely immediate implementation of a domestic gag rule in conjunction with a global gag rule, which we know a lot of Title X clinics left the Title X clinic network because of that gag rule of sorts. So that has serious implications for the delivery of care to disadvantaged populations in particular across the US, not specific to the states that have banned abortion. So a lot to try and disentangle, but these are all great points.
Yeah. Do we have time for one more? Yeah, I think so. Chelsea? Yeah. Mm.
So I was just thinking that it might be really interesting because on these reservations in some states, they have their own sovereign nations, they have their own regulated abortion care system. And so I'm just wondering like how that would influence the data. And I do think that these like abortion bans are significantly impacting this population. So I'm just wondering if you could you were going to try and include this data. I know it can be really hard because there's a lot of mistrust in like getting those records from those reservation clinics and healthcare systems. I dealt with that myself, like just trying to do that in regard to the COVID-19 pandemic. I'm just wondering, like, will they try to be included in future studies?
Yeah, so I just did some life table calculations for the Alaska Native American Indian population. And in doing that, I learned that their identification on death certificates is misclassified. It is underreported. And so what the National Center for Health Statistics does is they actually have correction factors. So that was something I didn't even know going into this work. And I'm just thinking about what that would look like for infant mortality. It might be almost impossible. But what we can do is instead of looking at this by state, we can look at just a comparison between banned and non-banned states. We would have enough power to do that. And we have talked about this population being a really important population affected by these bans. And so we know that we need to do a better job with this. It's just not possible in the current setup, but with the restricted data, that's the other thing is that for a lot of states, it's suppressed because the counts are less than 10.
Yeah.
So just a lot of challenges, but we are going to work to overcome those challenges. So,
and just to clarify, those data are in our analysis. We just can't separate them as a distinct racial and ethnic subgroup for the reasons Alison mentioned, but we will have them in the NCHS restricted data that we just got access to.
Yeah.
And yeah, especially in relation to infant mortality, they have the second highest infant mortality rate. So you would expect lumping them in with other, that's a really heterogeneous group, and it's probably masking some populations in particular that are especially impacted.
Sorry, this one, yeah. So in this other category, it's mostly non-Hispanic Asian and then non-Hispanic AIAN.
And multiple race.
And multiple race.
So
one of the things we're doing for the paper is in the appendix, we're going to say by state, the composition of that other group. And maybe people can make inferences if they feel comfortable doing so. But
one other future area of work that we're working with a colleague, Galeen Samari, who does a lot of work around immigrant populations, is disentangling for the Hispanic group in particular, his native born versus foreign born, to see if those populations are differentially impacted by these bans in relation to fertility. And maybe once we have the restricted data, could look at infant mortality and other health outcomes.
So I think we're out of time, but thank you, everybody.
Yeah, thank you for your questions.
Hopefully these will be published soon.
One day.